Okay, everyone, welcome back to another episode of ICU. I have a really awesome episode planned for you today. We have a really awesome guest. So I want to introduce you all to urologist Dr. Robert Moldwin. Welcome to ICU, Dr. Moldwin.
Thanks for having me, Callie.
Yeah, and
Sure.
I'm sure a lot of the listeners already know who you are, but I wanted to give you the opportunity to introduce yourself to the audience.
Oh, thanks. Okay. Well, as you had mentioned, I am a urologist. I work for Northwell Health. It's sort of, and also my academic appointment is professor of urology for the Zucker School of Medicine. And I work within the Smith Institute for Urology, again, within Northwell Health. I've been in the field, oh my gosh, probably since the early 90s, so well over 30, 35 years, something like that. I've been able to watch sort of the evolution of where nobody even knew what the heck interstitial cystitis, bladder pain syndrome, or anything was, to a point now where I think we are definitely turning a corner. We have a long way to go, which I guess we'll talk about today, but things have definitely evolved. I have a clinical practice. I direct the Pelvic Pain Treatment Center within my healthcare system. I see patients, of course, with interstitial cystitis, bladder pain syndrome. I see patients with prostatitis syndromes, pelvic floor issues, lots of different forms of pelvic pain. So I love it. I think we're making a dent in people's lives, in a good dent, not a dent like you have in your car. Okay, a good dent in a very good way. And it keeps me motivated, obviously, to do this. And been active in research, both basic and in clinical research trials. Um, which I think we need more of in this field, which is, I guess, is something else we could talk about in the time given.
Yeah,
So I
absolutely.
can go
What,
on, but
yeah, what made you specialize in like pelvic pain and interstitial cystitis?
that happened a long time ago. Well, obviously, but uh, so I was looking. I actually did my residency, my training in urology and general surgery in New York at the institution I work in right now, which is within the, again, Northwell Health. And when I finished up, my chairman at that time asked me to come on board to become faculty, and I wasn't sure whether I was going to do private practice, academics. I sort of liked research and all that. Anyway, long story short, I did a research fellowship in Philadelphia, had a wonderful time. It was in something really unusual. It was in host defense mechanisms, basically looking at how we avoid on a moment-to-moment basis of avoiding bladder infections. And in the process, I learned about this condition called interstitial cystitis, and I thought it would be an interesting thing to research, more or less as my little focus of academic interest. But at the same time, I could do all sorts of other things in general urology. And that was the initial plan. Ultimately, it sort of morphed into just pelvic pain because there's so many patients out there. I felt there was a ridiculously unmet need for services in this area. Nobody seemed to know how to take care of patients. And I sort of made it my business to do that. I joined forces very early on with the Interstitial Cystitis Association. So I was sort of not quite there in the first very few years, but I really got on board pretty early on. I was on the medical advisor on your, also you're part of it all, medical advisory board. And it's been, again, just a whirlwind experience, meeting wonderful people. People are really interested in helping others. I love the lobbying of efforts that we do. So I feel like my life right now is very multifaceted. We can, some of those services I've worked with the ICA have been in the world of even politics to try to get more research funding. I've had some of the research activities, and of course, I take care of patients on a daily basis. So it's been really good. In the process, again, I haven't been doing taking care of prostate cancer patients on a routine basis or kidney stones. I've really sort of very much super subspecialized in this area.
Hmm. Yeah, I think you're doing a great job. I honestly don't know how you're balancing all of that. Like, do you have a second to yourself at the end of the day?
No, I have to get into my sleep cycles now. So
Yeah. Oh my gosh, that's so funny. But yeah, so you've been doing this for a long time. You've probably worked
yeah.
with hundreds and hundreds of IC patients. So I think what I'm interested in learning more about is your approach when it comes to both diagnosing and treating interstitial cystitis, painful bladder syndrome.
So diagnosing and then treating, I'm giving my residents a lecture on that at the end of this week. I'm not going to pull out my slide set for you though. That's really
Perfect.
could be a little dull there, but how the general approach that I use in a nutshell is to figure out the pain generators, because even if we all know that we all used to think that interstitial cystitis was a condition where it was just a bladder thing, okay? And patients would come in with bladder-based pain, and they've been going and usually voiding very frequently because to get out of that pain. But now we really realize it's a very diverse group of patients, what we call in the science arena, heterogeneous, very heterogeneous as opposed to a homogeneous population. And having a heterogeneous population, everybody's a little different. We have learned within the past probably 10, 15, 20 years that not every patient's, all their pain is coming from their bladder. Some of the pain can be coming from other portions of the nervous system, what's called the peripheral or the central nervous system. Some of it even has to do with how we perceive pain, how we process it. We know that there are a lot of people who have associated pain syndromes, such as pelvic floor dysfunction, which is a whole lecture in of itself. And actually, early in my career, I'll tell you, I didn't even think, I was starting to think maybe there aren't any IC patients out there because nobody seems to really have their pain's coming from their bladder. It's all coming from their pelvic floor muscles. And we would treat that. We can get into that whole thing, but we would treat that and patients would like, wow, they would get much better. So it's a field, sometimes there are a lot of targets that you think are targets, but it's someplace else. And that's we've learned to accommodate for that by doing really detailed histories and physical examinations. Many patients have irritable bowel syndrome. Many of them have chronic constipation. They may have associated vulvar pain in the females and ejaculatory pain, for example, in the men. And we try to sort of focus in on those specific issues because, again, if we just treat the bladder, we may be on target in many cases, but in many other cases, we may not be, and the patients go on suffering. So we have to be sort of light on our feet. How do I go about doing that? I sort of alluded to this process of the history and physical exam. And if I could tell any of your listeners today what was probably one of the smartest things that they can do when they go to their clinician's office as a first-time patient is bring all your records, because many probably who are listening to this podcast have been to several different practitioners, and this person did this thing, and this person did that thing, and this X-ray was done, and that ultrasound was done, and that installation was done, and bring it all in, because we learn from that. We learn what to do, what direction to go ahead in, and which directions not to approach again. So that's really, really important. Don't have your doctors, just as a point of don't bring your phone with it. Try to get hard copies, because typically they'll want to scan that into your permanent chart in that particular office to take best care of you. So a lot of it is the history, number one. Where in the typical IC patient, we're looking for something that would denote pain that's coming from the bladder. So what would that be? Well, if my bladder fills and it starts to hurt more, well, that's sort of a giveaway. That sounds like bladder-based pain. It doesn't mean you can't have chronic pain, but at least that pain may get worse as the bladder fills. It may die down a little bit, maybe, when the bladder empties. And of course, to make the diagnosis, that goes along with that pain or discomfort or pressure goes along with what are called irritative symptoms, needing to go to the bathroom more frequently. Many IC patients in their history will get a detailed history. I know obviously this is near and dear to you, have problems with food sensitivities or beverage sensitivity. So we try to bring out that history also, which tends to be consistent with interstitial cystitis. So those are the things that typically, of course, the patients are not having one true documented urinary tract infection after the other. If we find any blood in the urine when we're doing, when we're doing urinalyses, we have to follow up on that. Could some of the pain be due to a stone, or could it be due to, God forbid, a cancer or something like that? We want to check all that out. And when we do a physical examination, we're really careful about testing, not just the palpating or feeling the bladder and pushing down on that above the pubic bone. We're interested in feeling all the different abdominal organs. When we're doing pelvic or rectal examinations, we're very interested in picking up pathologies such as, for example, in women who also are complaining perhaps of pain with sexual intercourse. Is it coming from something pushing against the bladder, or is it actually maybe the muscles within the vaginal vault, deep in the pelvis, what we call generically the pelvic floor muscles, and maybe they have dysfunction, what we call pelvic floor dysfunction. Other people call it high tone pelvic floor dysfunction. So we're looking for those other things. In the female, we often make Q-tip. We take a Q-tip and touch various areas of the vaginal opening, what we call the introitus, and we want to see if there's actually sensitivity there. So we're trying to pick up, again, not just the bladder in the history and physical, but we're picking up other generators of discomfort for the patient that probably have a lot of relevance. So let's say, and this is just a very classic thing. Let's say I have a patient, and yeah, they do have bladder. It sounds like they might have bladder pain, but they're also complaining of terrible pain with intercourse, and they also give me other complaints, like the urine's not coming out well. I don't feel like I'm emptying the bladder, and on the physical examination, we can see that the bladder is emptying. Those are some of those symptoms may sound like there's some problem with the pelvic floor. And then when we push on the muscles, if they're very tender and tight, I often elect to try to treat that first and then see where things go. That doesn't mean that the bladder is not a problem, but it means that I have definitely, or whichever practitioner you're using, may have picked that condition up. And that is very commonly a cause of people needing to go to the bathroom frequently. It may be a cause of chronic pelvic pressure, or just horrible pain with sexual intercourse, and in guys, pain with ejaculation. So we may send those patients right off the bat for physical therapy. We may give them muscle relaxants. We'll tell them to be in the hot tub, or not to go to a true hot tub, but yeah, get into the bathtub, warm or at least sitz bath, something to get the pelvic temperature up a little bit, and that usually really may calm things down. And then, sort of like peeling the onion, okay? We've taken care of that section, that peel. There still may be some pelvic pain left. Patient has bladder symptoms, we may start to focus now on the bladder. Now, how do I do that? What we do in our practice is we usually combine a cystoscopy. We actually look in the bladder in the office setting. There are very rare instances where I can't do that. If I can't, I can't. We do it in the OR, but most, I would say 95+% of people, we do quite well, especially, by the way, when their pelvic floor is treated ahead of time, because they can relax the muscles and the scope passes very easily into the bladder usually. When we're done, of course, we're looking for problems, or we're looking for tumors, we're looking for stones, we're looking for embedded objects. We could be looking for, probably most important in my practice, is are lesions in the bladder, inflamed areas, what we call Hunter lesions. Because if we find those, and those are usually found in older people, not a 20-year-old, we'll usually find them in people who are probably, I mean, the youngest I've ever seen really has been sort of in the mid-30s. But it's usually in the 40s, 50s, that type of age range. And those are treated, if we find these Hunter lesions, we'll treat them a little differently. And that's why it's important to find them early on. Let's say they don't have anything in their bladder, but they still say that it's hurting them as their bladder fills. Then we'll put into their bladder an anesthetic. We call it an anesthetic cocktail. It's usually two different agents. One is a short-acting agent called lidocaine. The other one's called bupivacaine, which is a long-acting anesthetic. And we'll put that medication in. We'll remove the scope. and we'll just see how the patient does. So essentially we're numbing up the inside of the bladder. And if the patient feels like, oh, gosh, I feel like a little more comfortable, that really, it's sort of like a nerve block. It blocks pain coming from the bladder. Patient feels better. Therefore, some of that pain must be coming from the bladder. So this is where it gets sort of interesting. It's great. I can help. It's not a perfect test, but it really does help diagnose what we call the bladder-centric patient, where when a patient really responds to something you put in their bladder. But it's only supposed to last for about 3 to 5 hours. That's how long these medications last. We don't have really long-acting anesthetics that go much beyond that. So the interesting thing is that many patients do go beyond that. And in fact, they feel better for days, weeks. We have patients now, a month at a time, one installation makes them feel more comfortable for a real long time. So it is helpful diagnostically. It also may be helpful therapeutically. So we're pretty happy with that. And to that point, there are a lot of pharmaceutical companies are interested in different preparations that might be helpful in that regard for that particular patient population. So I'm almost out of saliva, and I know we have a lot more time to go. So, but that's basically how I start things off. And I didn't even get into really treatments beyond the installation. So sorry for
Yeah.
that.
No, you're fine. I've had lots of thoughts. I'm curious, where do you think your approach to diagnosing IC, how does that compare to other urologists and urogynecologists? Do you feel like it's similar? Do you feel like it's different?
It's a little different. Yeah. I mean, so the American Urological Association guidelines, essentially, if um, so the diagnosis is made by the perception of bladder-based pain. That the perception, how I don't really know. Like some of my patients feel like their bladder is way higher than it actually is, like around their belly button. And it's not. It's actually just above and deep in your pelvis, but the highest it's going to get is maybe a bit above your pubic bone. But they don't call for, let's say, increased pain when your bladder fills and any decrease in pain. So they just want perceived bladder pain, no absence of urinary tract infection. They want you to have, of course, a negative urinalysis, no blood or evidence of infection. And you need to have some voiding symptoms, meaning that you're going to the bathroom more frequently than the average person does. So that's very, very broad, and that's probably why such a broad definition brings in a very broad group of patients. So that's so that's number one. Do they require a cystoscopy? The answer is no. You can and I don't have a problem with that. You don't need a cystoscopic examination to derive a diagnosis of interstitial cystitis. I think that amongst clinicians out there who are experts in the field, most of them are sort of leaning towards doing cystoscopy, whether it be in the office or the OR or what have you, to rule out various pathologies, as I mentioned, like the Hunter lesion patient, where if you have a Hunter lesion, probably just changing your diet or or taking some simple medications is not going to really help you. You really need some type of usually some type of surgical management, or at the very least medications we can put directly into the bladder. So I think that is something that there is no although we'd like to change things, I would love to see the field move forward into where they use these anesthetics a little more, not just they're used therapeutically now, but they really can be used to help in diagnosis,
Mhm.
I think.
Yeah. And I don't know if you remember, but when we were on the last medical advisory council meeting, I was saying how there's a lot of fear surrounding the cystoscopy process in the IC
Yeah.
community. And, I personally have had a bad experience where it was done in office. There was a lot of pain, a lot of pain afterwards as well. And I think when IC warriors are sharing their stories with the cystoscopy, they can be almost like scaring people who may need to get one in the future.
Uh-huh.
What are your thoughts on that?
I mean, you sort of have to know your patient. Everybody's a little different. Um, by the way, I have like some kind of weird, do you see like some
Yeah, it's a little glare, but
semicircle?
I can still see you.
I know I'm in a rainbow right now. Oh, there.
It's magic.
I have no idea what that's about, but all right, I'll sort of move this screen. Okay, no, there again. All right. Did something wrong here, but all right, we'll deal with it.
Cool
I'll
deal.
just move over this way. Good. Um, yeah, you have to know your patient. I think that I've I think when I do a cystoscopy, or I would hope when my residents who I train do cystoscopies in the
Can we do a
future.
TV timeout? I'm so sorry.
Yeah,
I
sure.
lost you there for like 20 seconds.
Okay.
Would you mind just starting over?
Sure. You mean just knowing your patient?
Yes.
Sure. Yeah.
Sorry, it completely froze.
That's okay. So I would just say you have to know your patient. That there are some patients, there's no question. I mean, they're terribly tender. Their urethra is tender. Their pelvic floor is one big tight spasm. It's hard to get the scope through. But I can tell you that I think that again, the vast majority of patients were able to do it with a lot, pretty easy. Little easier in women than in men, interestingly. Um, but I think that just using a gentle process, using plenty of anesthetic jelly, of really sort of being the patient's cheerleader through the whole thing, and working with just relaxing the muscles of the pelvic floor usually does the trick. And most people do really well. I mean, I tell patients, I will never forget this. I had one patient like years ago. She was crying after the cystoscopy, and I was like, I felt like, did I hurt, did I hurt you? Um, she wasn't crying because she was in pain. She was crying because she was so, pent up about the whole thing. And when it was over, it was like she sailed through it. She had no problem, and it was just like this whole release of emotion. So again, it's everybody's a little different. I always tell people, listen, if it's hurting too much, we'll just stop. End of story. I get information like that. I think that just as a detective to trying to figure out where pain is coming from, I just find that the cystoscopy is helpful in the office because then the patient can tell me, does it hurt here? We use a flexible telescope. So if I touch here or deviate my scope in a certain way, it gives me information. Also, having the ability to have the patient awake, put the anesthetic in place, and have them see, because then they're not clouded with an anesthetic that they would get in the operating room. They can actually truly see if the anesthetic in the bladder is helping them. All that stuff is very helpful. So I'm not saying, there are no rules here. I think everybody is, as people have said, is a snowflake. Everybody is similar, but they all have differences that make us unique. And I don't have, I don't believe in a cookie cutter approach to these things. You really have to move to where in this field to move in the direction that's the most clinically important for any given patient. I always tell people, this is not like fixing a hernia. You know what I mean? It's not like, okay, I can look it up in a textbook and just put stitches in here and a mesh here and whatever. It's a well-defined problem. It's a well-defined way to fix it. Done. This is detective work. It's frustrating. It's trial and error. But I think, when you work as a team with the patient, things get done.
Yeah, absolutely. And for those people who on a cystoscopy, you're not really seeing anything, their bladder wall looks, fairly normal and healthy. Like what do you do from there?
So, I mean, the first question, so if it looks pretty healthy, everything looks fine. One thing I'm interested in seeing, again, while I'm seeing the patient in the office and doing that cystoscopy, I can assess how they're feeling as the bladder is filling. So I'm saying, am I reproducing some of the discomfort or pain that you've been getting? So that is very helpful to me. Um, so if I see that they can't really hold it looks perfectly fine, but they really can't hold a lot of fluid in their bladder because it's really getting uncomfortable. And I really think that this patient probably has some bladder-based issue. I'll start them on therapy. So what is the therapy? The therapy is just like I say, it should not be a cookie cutter approach. We have lots of things on the menu. The question is, what kind of patient are you in terms of severity, in terms of your symptom complex and so forth, and how do we match it up to what's going to help you the best, okay? So as I say, let's say I evaluate a patient now, and the patient, I'll give you a clinical scenario. We'll say it's a female patient, they're voiding twice a night, they have pain with bladder filling, I look in their bladder, I don't see a thing, okay? They're not getting infections, they've been told, they've been on it, and you know the classic, I've been on this antibiotic and that antibiotic, and I've gone through this little gauntlet of clinicians not going anyplace. So, you know, the first thing I have to figure out, I usually figure out does this patient have pelvic floor related issues? If they do, as I alluded to early, I will start that type of therapy right off the bat. And then usually I'll have them come back to the office to reevaluate, see how they're doing. And then I'll start to say, well, you're still going to the bathroom twice a night, right? You're still having pain with bladder filling. What are medicines that might be helpful to treat the bladder per se? And what things can you do in your own life to make you feel more comfortable? If you have severe symptoms, so let's take that patient who's going to the bathroom once a night, going to the bathroom a lot during the day, increased discomfort and pain with bladder filling, but is giving me, it's interfering with the quality of life, but it's not that horrible. It's been worse in the past. So, and this patient, let's say, is diet sensitive. So this is a good patient where you might say, listen, this is great. You're diet sensitive. Let's talk about elimination diets, things like that, something like that. Maybe some supplements, whether it be, calcium glycerophosphate or whatever it might be. We can go in that direction to stay really conservative. We'll talk about, for example, behavioral changes. A lot of the patients tend to be clinchers. They're always tightening up their pelvis because they're in pain, and teaching them that that's not a good thing to do, okay? To try to change certain lifestyle changes can be very helpful because we do know that stress tends to also cause symptom flares. If they're having sexual issues, we might talk about ways to make that go easier. A lot of that stuff tends to be related to the pelvic floor related stuff, so that goes into that category. Other things now, what happens if the patient has, okay, we're still talking about the patient who has nothing seen in their bladder, but what happens if the patient had that installation in the bladder earlier on to try to figure out what's happening, and they felt awesome? Well, and a lot of our patients have a lot of medication sensitivities. Well, that might be a great patient to say, listen, if it helped you that much, maybe the easiest thing to do would be just to, instead of giving you things by mouth and different medications, what about giving you an installation into the bladder? It helped once, maybe it'll help again, where we can put you on a series of these to see if we can get some of your symptoms under control. So there are different types that we can go into that if you wish, but there are different types of medications that we can put directly into a bladder. But that might be reserved for maybe a patient who has more severe symptoms, or again, a patient, like I said, this is not it's a big menu here. And people do things because it fits their lifestyle or what they want, and even their general things that they can tolerate medically. But a lot of patients love that. And what we've been doing most recently, we had one of our medical students present in Toronto at the International Continence Society meeting. It was a great presentation. And we talked about you talk about patient empowerment. We're working with cell therapy. So if you respond to a medicine that's instilled directly into your bladder in the office, we have really smart patients. We can teach them how to do it themselves. So, and they do. And when they get into a flare, boom, in goes, they put the catheter in, done. And they get back to work, they get back to their social activities. It may make the difference between being able to hang out and actually see a play, in their neighborhood or wherever, or, staying home and thinking about their bladder. So these are really great things to offer patients. The biggest problem we've been having with that is insurance sometimes doesn't pay for the equipment, which is really annoying. Anyway, that's another story.
Yeah. I used
So
to do installations at home and I was paying out of pocket, but it was like half the price of getting it done in the office. So it definitely was worth it. And I agree that it's really empowering to be able
yeah,
to do things yourself. So I think that's a really great thing to bring
yeah.
up.
I just don't think, people have jobs, people have lives, and to have to live your life in the office, that's just depressing. Why would you want to be in the doctor's office all the time? Listen, we have made great friends with so many patients that way, but still, it's not the place to be.
Mhm.
And like I say, there are medicines. There are medicines out there that have been helpful. That's one of my biggest, frustrations is just the fact that we don't have enough medications. Almost everything we use is off-label. It's not FDA approved. We're using them from other, medications with other indications, medical indications. Thank goodness they work for a lot of people, but they also have their potential problems with them.
Are there a few medications that you're finding are more helpful than others?
Well, again, see, this is where you have to sort of pair the patient to the medication. So the classic one, of course, was and the only one that is FDA approved is Elmron, which is the pentosan polysulfate. So the biggest issue with that medication and is that well, there are two. One is not sure how effective the medication is. I truly believe that there are a group of patients where it really is miraculous. They use this medication and it has clearly helped their symptoms of interstitial cystitis. I've encouraged them to stop it or go down on the dose, and symptoms come back, and we go back, and it's sort of like what you might do with foods, right? With elimination diets, is it helpful? Is it not helpful? So that said, there's some new data that, of course, has come out about some ophthalmological issues, something called a pigmentary maculopathy. That can be, we don't know if it's necessarily if it's a cause and effect issue, but clearly there's some association present. And so we advise now patients, if they want that medication, to at least get a baseline ophthalmologic exam. If they have eye problems, obviously to follow through. And they should still, even if they're on the medication, just for safety's sake, keep an eye on it with the ophthalmologist. But those are the basic, the generalizations about that medication. I wish it, but that's what we have. That's the only oral medication. The only other medication that's FDA approved for interstitial cystitis is DMSO. It stands for dimethyl sulfoxide, and it's one of the medicines that is used placed directly in the bladder, usually as what we call a cocktail. So it's mixed with other medications, whether it be a steroid, an antibiotic, sodium bicarbonate, et cetera. But those are the only two. The ones that I think have been very helpful to patients, but now we're also having some concerns about these medications, are what are called the tricyclic antidepressants, the amitriptylines, the nortriptylines, and they really can help people sleep. But they can help people sleep. They block pain. They function as an antihistamine, and they relax the bladder at the same time. The problem is that they have certain effects that basically make the bladder. Sometimes people have poor flows to begin with. it gets worse on this medicine. So if you have a poor flow and you push urine out normally, putting people on this medication may make that worse, and therefore you try to help the patient, and the whole thing backfires. Those medicines can also cause constipation, and if you're constipated to start with, this could make it a lot worse. And so you have to take these things into consideration. If you have heart disease, arrhythmias, they can actually affect the heart rate, conduction, and so forth. And I always recommend people to see their cardiologist to get it cleared if they want to take it. So yes, and it also can make it easier to gain weight. So all sorts of wonderful things. But a lot of people don't get those side effects, and it helps them, and it's a really great thing. The problem we're having with these medicines right now, and this is not just people who treat interstitial cystitis, but these medicines called the tricyclic antidepressants, along with, by the way, just regular bladder relaxants like oxybutynin and so forth, and I can list about 7 or 8 of them on the market, but basically all of them can cause or have been associated with cognitive difficulties. So most recently, the past few years, again, another association being found and thought maybe linked to dementia, presenile dementia, Alzheimer's, and so forth. So, what I tell my patients is, if it's helpful, and any medicine that's helpful, I'm very happy it's helping. You should know what the potential downside is, and always, if you're going to use any medication, it's just a good general principle. If you don't need it, don't use it. Okay, test it out periodically. Some people take medicines for like 25 years. They don't even know if it's helping them anymore. Stop it, start it if your doctor says that's, if that's okay. There's some medicines you don't want to stop cold turkey. The other thing is you want to take the lowest dose. If you need it, take the lowest dose that's going to help you. If you don't need those extra milligrams, why use them? Because you're just going to run into more side effects when you do that. So those are my general. The other medicine that we use very frequently is hydroxyzine, and that's a first generation antihistamine that really helps people sleep a lot better. It helps if you have a lot of allergies. It seems to help that, of course, also. Good for flares. Also may have some potential, it's a little bit of a muscle relaxant as well. So it's an all-around pretty good medication. Really helps with sleep a lot. For people who just don't feel comfortable using the medicines, the tricyclic antidepressants, again, the amitriptylines, the nortriptylines, et cetera. The problem is with those medicines also have been implicated with those cognitive changes. So there you go. So no easy way out of this business right now. In those instances, so now we have that patient, you'd say, well, how do I organize this for any given patient? Well, I have to know about, if a patient is already constipated, I have to factor that in. And that's why this is sort of like a little, I'm not going to say I'm not good at Rubrik's Cube, but it is sort of like a Rubrik's Cube. You have to, okay, well, this patient has got constipation, difficulty voiding, but I think would really benefit from that medicine, but the medicine may cause a problem with their flow, okay, and they already have a poor flow, and then they're going to push more. Why do I want to start in with that? And that's when I start reaching out for other medications that might block pain, and things like you have to think about, although it's not in the ICA guidelines, excuse me, in the AUA guidelines, I at least think about medicines like gabapentin, like pregabalin. These are anti-seizure medications that have been used very frequently, now also off-label, for the treatment of other pain conditions.
Mm-hmm. Yeah.
Does that make sense to you? I mean, again,
yeah.
You have to be very sort of light on your feet here. And I'll tell you something, to the AUA's credit, it used to be that it was like a tiered system. So every patient would go through, well, you have to start off from the most conservative to most aggressive. Well, that's a good general guiding principle. I totally get that. But the problem is, what happens when the patient comes in with super duper severe symptoms going on for 7 years? What are you going to start doing? And I can tell you, it's not, you can do as many dietary changes and, maybe, even hydroxyzine or whatever, basic therapy. You need to be more aggressive with those patients. And that's what makes them feel better sooner. And that's what, that's the challenge.
Hmm. Now, after working with so many
I
people
can't hear you.
and
I think
oh,
are you on mute?
no, can you hear me
Oh,
now?
oh, turn up volume. I have to turn up volume. Okay.
Can you hear me now?
Oh, yeah, I can.
Oh,
Okay.
okay, I'll step back.
I turned up my
Um,
volume. Yeah.
in working with all of these IC patients, I know there's lots of, or a few different like phenotypes and subtype theories coming out. Do you agree with any of these theories, or are you seeing something different in your practice?
The phenotype theories? What, I'm sorry.
Yeah, like how Dr. Curtis Nickel came out with like 9 different phenotypes. I've seen, from I think UCLA. Was Dr. Ackerman involved in something with phenotyping?
I think that you cannot, if you are seeing patients on a routine basis, and you're an observant person, you will see these phenotypes become second nature. Okay. You see patients who are, one phenotype that's clearly, and by the way, this is the problem. It's naive to think that there's only one there are only X number of phenotypes. They all may blend into one another. That's the problem. So, for example, someone will say, well, let's talk about the patient comes in with, quote, the centralized phenotype. And this is a patient, for example, who may have lots of pain sites in their bladder, in their bodies. They may have a history of chronic fatigue syndrome, fibromyalgia. They may have irritable bowel syndrome, lots and lots of things going on that many of these processes or many of these forms of pain may have uh, a great degree of their pain coming from their central nervous system. And you can pick that up very quickly because, again, they perceive the pain's coming from their bladder, but you can't feel anything. They can fill their bladder up to, huge volumes. It doesn't hurt them. You put medications in their bladder, doesn't change anything. It's perceived there, but it's clearly there's something else going on. And those are patients who are probably going to do better with, just to cut to the chase, they're probably going to do better with medications that have more central activity. So, for example, the tricyclic antidepressants, the anti-seizure medications like gabapentin and all that probably have more of a role in those patients than, putting a medicine directly into their bladder. It's going to have it's probably not going to have any value. There's another, phenotype where we're sort of missing the boat, as I mentioned, the myofascial patient, the patient who perceives that the pains or the discomforts from the bladder and does have to go to the bathroom a lot, but you examine them, you get more history, and there's no question about a lot of their pain, and maybe even the pain with intercourse and all that is due to musculoskeletal issues. And yes, so you're going to go in that direction, muscle relaxants, physical therapy. So phenotyping probably has a lot to do with what direction we go therapeutically. And I think it's important to realize that. But I wouldn't, I don't think I think this is something that we've known as clinicians probably for a good 25, 30 years. I mean, like I say, you start to see things over and over and over again. I don't know if I'd put out 9 phenotypes, but I think the real important thing is what I teach people really is that the most important thing really is to be a good detective. You really have to do that good history, the physical examination, and you do this basically confirmatory laboratory testing and little maneuvers, whether it be cystoscopies and putting anesthetics in the bladder or what have you, to figure out what's going on. And also the other thing is one phenotype I say is not exclusive of the other. So you can have a patient who has perfect example. I may have a patient who is on, let's say, gabapentin, but I'm also doing instillations in their bladder because they do have some local pain that is really being helped with medicines placed directly in the bladder. But at the same time, there's probably some other component, what we call that centralized component, nerve component to their pain, which is helped with these other medications. And at the same time, that patient might even be on physical therapy because their muscles of their pelvic floor are very high tone. When you push in on them, it causes a great deal of pain. It may even reproduce what they feel is bladder-based pain. So they could be on that also. I mean, we call it, honestly, it's called the I guess the negative trifecta, the bad trifecta, where you have bladder-based pain, vulvodynia, and pelvic floor dysfunction. We have many, many of these patients. So I say, if it's, I think, again, a little naive to think that you're just a pelvic floor patient and you're just a central patient. It doesn't, it's more complicated than that.
Mhm. Yeah, it goes back to being a very diverse population, and it's
Right.
important to take that individualized approach. I love that. I think a lot of people in the IC community get caught up on these like new phenotype theories that come out, and we just kind of like hyper focus on that. So
Well,
it's
no,
good
but
to hear.
I'll tell you something. So the phenotype concept, I mean, I don't even think it's a theory. I think it's an observation more than anything else, because it is there. I mean, there's no question that there's, the trick is, I think, for the future, is to use what we know as clinicians to develop better research studies. So as an example, let's say I'm a researcher and I want to research a medicine that I want to put in the bladder, and it's going to make all bladder pain go away. It's going to last for 2 months. Wouldn't that be great? Maybe more. It's going to numb up that bladder, make you feel. But supposing when I go and I try to find my interstitial cystitis patients for my study, supposing who knows, I just not good at picking patients, I guess. I pick patients who have their pain really isn't coming from their bladder. It's really coming from their pelvic floor muscles, or it's really coming from endometriosis, or it's really coming from something else, and they perceive it's in the bladder. We have a problem here, because now you're taking the population and you're putting in people who would never, ever have responded to the medication to begin with, because they don't have a bladder problem, right? It's like
Right.
treating, people with doing a study on bladder cancer and putting 50% or 70% of the patients involved, they don't have the bladder cancer. It's gonna mess up all your results. So anyway, so that's the problem. And I think so in the future, I think what we're going to be doing is hopefully relying on picking these populations and using and pairing them up with appropriate therapies. So if I have a new medicine, let's say I want, a new medication that's going to relax all their pelvic floor muscles, and it just goes straight to those muscles and relaxes them all out, and that is a great thing. And I pick all the patients with pelvic floor problems, I'm going to have probably a real success there. And the same thing with the people who truly have bladder-based pain. Match it up one to the other, and you're going to get good results. But again, I think that's the reason for so many of our failures in clinical trials, and we have to do something to change that around.
Mhm. Yeah, definitely. Um, Another thing I've been wanting to ask you was how many people have been diagnosed with IC that you think are actually misdiagnosed?
Um, a lot. Um, I'd say still the most common, is pelvic floor problems, because they overlap so much. We still get, it's yeah, that's probably the biggest problem I see. And conversely, there are some people who, when you're a hammer, everybody's a nail. There's some people who they walk into an office and tell the story and get examined, and automatically, no matter what, they're going to go and get pelvic floor physical therapy and injections into the muscles and muscle relaxants and all that. And basically there's nothing wrong with the muscles. It was a bladder problem. So I think all of that really comes, yeah. So again, just to emphasize to clinicians in general when we teach, to do a really good detailed history physical examination, so you can have a practical approach to getting the patient better faster. That's really what it boils down to. But
Mhm.
yeah, I'd say it was probably worse when I first started practice. But I still see it over and over and over. It's a real, real problem.
Do you think a lot of doctors out there are just giving people the diagnosis when they're not really sure what else to do?
Um, Probably. I mean, I do. It's always been considered by many people, I hate to use the term waste paper basket diagnosis, what they can't see, they just poo-poo. So that's obviously what makes it's always made it hard for patients. I think now, as I've seen the whole field evolve, I think that people certainly all of a sudden now everyone can pronounce interstitial cystitis, right? So we know what it is. They even know what IC is, and people are getting a hold of that bladder pain, the BPS thing. But you're right. I mean, I think that there's a tendency to just call it IC and that's it, and we just throw you through a whole mess of things and it doesn't work and you wonder why. And again, you have to really evaluate the whole person.
Yeah.
The other thing is, I think, it's as they say, the devil is in the details, right? I mean, the other thing that I find bothersome just in practice, just patients who come in, I've had to sort of critique my own profession, is just that they don't get counseled a lot. I think that there are practices where the clinicians themselves or, allied health fields or whatever will spend time doing it. But a lot of places they just sort of, this is what you're getting. They don't have much of a choice. It's not really much of a conversation. And they very, very frequently, we're finding right now, at least in our community, that for example, when people feel like there is some problem with the pelvic floor muscles, they say just go to physical therapy. It's almost boom, off you go. And I don't think that it's not just people who have pelvic floor, and I know I'm digressing. This isn't specifically related to bladder-based pain, but there's no real discussion about behavioral changes. How do you change your sexual activity? How do you change what you're doing if you're going to the gym? How do your exercising activities? How about where you're sitting? What kind of seat support do you have? Are you a clincher? As I mentioned, we have so many of the patients, or they have pain, so they guard and they clamp around that pain, which makes the problem even worse. So you see a lot of these vicious cycles. So I always tell people you can go to the physical therapist and they can do some really wonderful things to help relax and get these muscles less dysfunctional. But at the end of the day, if you walk out of the office and you head on to the gym and you do, this is, 100 squats, I can tell you, you're not going to do
Hmm.
very well overall down the
Yeah, and
bike.
you're wearing
So,
your
yeah,
leggings and you're not
yeah.
hydrating. Yeah, that's gonna get you.
Or you go down to you finish up with the physical therapist and you go in again into clinching mode. So many patients are, it's funny how many patients COVID was really tough when everybody was in masks. I couldn't watch their jaws moving, but so many of our patients have difficulties with grinding and TMJ issues. And it's interesting. It seems to be some type of a global event. They clinch down below, they clinch up top as well.
Yeah, I actually had a pelvic floor PT come on and do an episode on the pelvic floor and like TMJ
Uh-huh.
dysfunction, which was
Mm.
really interesting. Um,
So we did a study a while back, which this is with Dr. Balani, and it was actually very interesting. We found that about 75% of our patients who have pelvic floor dysfunction um, clench their teeth. So very interesting association
I
there. And
don't
that's
know if you've been watching my jaw this whole time, but I'm
no, I've
sure
been
something's
watching. Oh
happening.
no, no, you're pretty good. You're pretty good.
Yeah,
Yeah.
definitely common. I mean, among my clients, I definitely have noticed that. I've also noticed that a lot of people I work with are really high anxiety perfectionist type people.
Yeah.
Do you notice that?
Yeah, sure. I mean, I always tell people sometimes what makes you really good at your job or, certain activities or whatever, is killing you in the medical end of things. Because what happens is, it's almost like that sort of I'm not a psychiatrist, but, again, you can see obsessive, very type A plus personalities, obsess a little bit. And once they focus in on the bladder that this is a problem. Again, being a perfectionist, they're looking and trying to change things. Their brain just goes straight down there, and having diversions, having things to do. That's why I say it's best thing to do is to try to your best to stay out of doctors' offices and do things yourself at home, whatever you can do, because when you sit at home and it's quiet in the house, that's why so many people have difficulties at night. You just sit there in your bed staring at the ceiling and waiting for your bladder to fill up again for the pain to start. You become very focused, and then of course what happens is that brings on more stress, that a lot of people start to tighten up then their whole bottom, and and pain worsens, and then they tighten up more, they get more stressed out, they focus more, and it just never stops. So people really do need things in their lives, I think, to keep them well, partially to distract them, and also to avoid getting into these cycles, to be aware also when you're getting into a cycle. That's why I really push with my patients things like meditation, which I think has, as soon as I have a lot of patients who just say, I just don't have the time for it. Well, maybe that's the problem.
Yeah.
All right. Yeah, these are things, especially with the younger patients, where there's, I said, you're 25, okay? You have decades and decades ahead of you. Now is like the perfect time to start to learn how to control your body and to do the meditation, to learn the yoga techniques, or, do these things that are really going to help you. And yeah, of course, I shouldn't leave out if, it could be me too, right? So if you're older, it doesn't mean to poo-poo it either. You can start anytime. Those are really things that help you. I don't think just for medical related issues, just for your peace of mind, and really, like I say, I've told this to many a patient. Some of my worst patients, where medicines were not really doing the trick, or they were getting side effects, all these different things. They went and finally bit the bullet. They spent the time not just getting an app for meditation, actually working with somebody, working with a class. I mean, the apps are okay if you can stick with them. I know I cannot. I need somebody to push me
Yeah,
to
there's
do
no
it.
accountability with them.
Yeah. So yeah, and I have not had one patient come back to me and say that was a lousy thing to do. They all come back raving about it, and not only that, in some of them where everything was failing, that's really what broke through the ice. It really, really made the difference for them.
Mhm.
So I can't. So I always say, just because something is more aggressive therapy doesn't mean it's better. Right? So sometimes it's the simplest things that you tell patients. Just like I tell people, you cannot be constipated if you're having any form of pelvic pain. And some people, once they start working on it more effectively, maybe even work with another clinician to do that. It's part of the puzzle to get you feeling better. So.
Mhm. Yeah, amazing. I think we've talked about so many different really helpful topics here. I wanted to ask you any final, pieces of advice for anyone that's struggling with interstitial cystitis. It could be literally anything, but as a practitioner, do you have any words of advice?
I think that uh, the probably first of all, you can get a lot of stuff online these days, which I think is something that I never, when I started in this field, you just it was there was nothing. There was no YouTube. We didn't have any of this stuff. No blog, no podcasts or anything like that. So the problem with these things and getting on the internet is also you're going to find things that are a little out there, and it's sometimes very, very difficult for people to to decipher what's going on. And you should, I think it's important to bring these things to the attention of, your clinician. Pick a clinician who's not necessarily a major expert in the field, but really somebody who's going to be your advocate and try new things. I mean, I get calls all the time from my residents who've left the program who have an IC patient, and they'll call me. What do you think I should do? They'll present the patient to me. I'll tell them what I think. So again, you want somebody who's going to be with you. Again, doesn't have to be a doctor, can be a nurse practitioner, who I think are often are PhDs these days also, but what have you. But again, someone who's knowledgeable, who's willing to work with you. I think you should query your clinicians about things that you can do for yourself at home. Things like, again, things outside the office, just like you were mentioning for yourself, self-therapy if you can, with installations, things like that to keep you out of the office. I mentioned already, just as a simple thing, is to whenever you're seeing a new person, any new practitioner in the field, bring all your records, because I can't tell you how helpful that is. At least it is in my practice, because a lot of the other clinicians have done the work for you. Okay, they already, you did very poorly on amitriptyline, or you did really great on this installation, or you did. So it gives us a roadmap of where you've been and can give us some direction as far as where to go in the future. So I think that's really, really can be a benefit, again, to get you moving through the system faster. Aside from that, I think, one thing that's happening right now, I find, certainly in the New York area, is that patients are running around and seeing a gazillion doctors at the same time. That's not a good idea. If you're going to, my suggestion is, if you really are not hitting it off with a clinician, then leave and go elsewhere. What we're having a problem right now is some patients are saying they decide they're going to see Dr. X, Y, and Z, and then have another consult with another doctor. And, that's not going to work. That's going to hurt you, because then you're getting different opinions from different people. As I say, this is a very individual, it's sort of an art form in itself. And you can't really, and it's not that one's way of treating is any better or worse than anybody else's. But when you start mixing different recipes, it's could be disastrous for the patient, especially in today's day and age where you have all these different healthcare systems. This person, and you're going to have right hands not knowing what left hands are doing. So that's something that you can really fall into a trap with. So very, very, very careful with that. I think that some of the things that I had mentioned, don't assume that your drugs are all helping you. It's not a bad idea to try a drug holiday. I think that's really important. Again, the key is that every drug has side effects. That's how it is. But you want to minimize all those side effects, and by making sure that you really do need to be on the medicine. And when you're on the medicine, you want to be on the lowest dose that's going to help you. You don't, why get side effects from taking high doses that you don't need? I guess those are some of the little tips I would give you. General tips I would give you, or your listeners.
Yeah.
Listeners/watchers. Okay.
Yes, I think all of these words of wisdom are really going to go far with some of these listeners. So I just wanted to say thank you so much for, giving us an hour of your time. We appreciate all that you do for our community, and we hope that you do some more research in the future.
Thank you. It was really wonderful being with you. Thank you so much.